Good evening to everyone. I'm Dr. Onkar Swami on behalf of MQ Pharmaceuticals Limited. Welcome you all in this webinar of what's new in opportunistic infections with HIV. We all know HIV-associated opportunistic infections encompass a myriad of life-threatening infections seen in patients with an advanced immunodeficiency virus. We also know these infections are typically affect with the people with a low CD4 count. So this webinar is planned to discuss about what is new and what are the recent updates in management of opportunistic infections with HIV. And to take this program ahead, we have an interesting speaker tonight. It gives me a privilege and honor to welcome our faculty and speaker for tonight, Dr. Ashwini Tayade ma'am. She is a certified in tropical medicine at ASTMH Atlanta at USA. She is currently practicing as a consultant infectious disease specialist at Kingsway Hospital, Nagpur. She has been a member of Governing Council of Clinical Infectious Disease Society and an organizing secretary for past SITSCON 2017. She has been awardee of a Young Achiever Award as a Vidarbha API Vepicon in 2020, and she is a regular faculty for many state level and national level conferences, and she has a keen interest in adult immunization, HIV, and multi-drug resistant tuberculosis associated with HIV and zoonosis. Thank you very much, ma'am, being a part of this webinar, and we look forward for your interesting presentation encompassing what are the new development in opportunistic infections with HIV. At the same time, I would like to share our product range at MCure, and this program is brought to you by Spegara from the MCure. So with this short note, let us go to our speaker, to Dr. Ashwini ma'am, for further deliberation. Over to you, ma'am.
And like we know, with the advent of newer antiretroviral, the management of HIV has become really easy. And the previous era or previous decade, wherein we used to have a lot of issues with drug resistance, managing drug resistance scenario and all those things, those are no more so challenging. Yes, definitely with the subsequent use of Dolu, we will see Dolu resistance, and that will be a next issue we'll have to handle. But fortunately, as of now, we don't have that issue, and managing ART has become a easier task, I'd say. And now what is challenging in HIV is really managing OI. I would say picking up OI in time and then hitting it hard is the key of managing HIV. That's what I feel in today's era. Definitely having a good ART on board makes our job easy. So what I'll be doing today is few of my cases I'll just share with you, and through them we'll just discuss the OI, what we see in our HIV practice, and which is really challenging sometimes, because even with the best of investigations available, it becomes difficult to get hold of exactly what a OI patient is having a opportunistic infection, and sometimes we miss the bus actually. And unfortunately, in fact, I have had situations where I have lost the patient despite of complete workup because I couldn't pick up the OI in time. So for me, picking up OI and knowing about the opportunistic infection and being up to date about it is really crucial. So we know, yes, in India, the number of PLHIV is significantly higher, almost 44 lakhs, though the number has going down in last 2-3 decades, the number has significantly gone down. But then AIDS-related death is still 49,000 in 2021, which is significantly higher number. And Maharashtra leads it among the top 3 states which are leading. In Maharashtra includes 12% of it. Then come Bihar and Uttar Pradesh. Pediatric population is also a part of it, which is almost 0.7 lakh, which is a good number. Adult, nearly 23%. So if you have this data, male and female more or less same. This is the motto. This was a motto, in fact, by 2020, 95. That is the number of patients diagnosed on treatment and virologically suppressed should be 95. So out of which what we have achieved is 77% of them were diagnosed, 84% were or put on treatment, and 85% of them are virologically suppressed. So that means we are still missing out 15% of those who are not on treatment. We are missing out 20, almost 30% of those who don't know their status, and 15% of those who are virologically suppressed. And this is a population who is prone for opportunistic infection. And we know India is a hub for TB, and TB can happen even at even with well controlled, biologically controlled patients also. So we have to always keep our eyes open, and if there is a suspicion, we should never neglect it. So as I said, yes, TB is the commonest opportunistic infection what we see in our practice, day-to-day practice in our HIV population, PLHIVs. Then comes oral candidiasis. Diarrhea is a common symptom what we get the patients with. Those who are newly diagnosed, and sometimes even those who are virologically controlled, we do get diarrheal episodes. Zoster is one thing which is sometimes missed because they go to GPs or it get managed at dermat level. But yes, zoster is even an important chunk of it. And then comes cryptococcal meningitis, pneumocystis, CMV retinitis, toxo. So CMV, toxo, all these are going down day by day. Subsequently, we are seeing few cases, but those which are there, sometimes they come up with a googly, or they come up with a rare presentation, or some unusual things we do see. So we are well aware about this time period, and what we see at higher CD4 is mainly non-infective, like GBS and all these. Those who have low CD4, what we see is those who have less than 100, what we see is CMV, PCP, Cryptococcus and all this. And the other thing we need to keep in mind is the lesser is a CD4, higher is the number of OI, and it can be multiple OI at one time also. So not necessarily if we have picked up one OI, we should sit tight and observe. If patient is not responding, yes, we should keep looking for what else we are missing for. So this is a list of OI. I'm not going to detail of it. We are aware about it, which varies from bacterial, viral, fungal, parasitic infection, and all sorts of system are involved. What is more problematic is central nervous system involvement, the meningitis, cryptococcal meningitis, what we see. Syphilis, yes, it is increasing, but so far we haven't seen neurosyphilis cases. But yes, the incidence on syphilis is definitely increasing. The other thing I'll highlight is pneumocystis pneumonia. Getting a diagnosis with advent of PCR availability, yes, it is okay to get the diagnosis of pneumocystis pneumonia, but quite a few number of time it's clinical and radiological diagnosis what is available with us. And the diagnostic dilemma then comes is whether it is just pneumocystis, or there is overlapping MTB, or there is overlapping CMV, though which is not common. But if the CD4 is really low, we have to keep all these possibilities open and look for it. The common symptoms what we see in them is fever, weight loss, then respiratory symptoms, cough, dyspnea. They do come up with lymphadenopathy. There are so many patients who just have a symptomatic lymphadenopathy, and they're coming to you with fever, malaise, weight loss. The diarrhea and abdominal pain is another common symptom. Sometimes they have skin lesions. The skin lesion might be just the purpura, pruritic lesions, or it might be a fungal tinea, or sometimes it might turn out to be cryptococcal or histoplasma skin lesion if they are nodular skin lesions. Then night sweat, altered sensorium, basically all these related to neurological presentation if we have. If we think of CNS OI, what we have when we talk about the etiology related to CNS OI, what we have to think is whether it is acute or chronic, whether it is a opportunistic infection or it's CNS lymphoma is a possibility, or we are thinking of something else. Metabolic and nutritional derangement, all these things also we have to keep in mind. Sometimes it's just complication of medical therapy, like previously with efavirenz, we used to have CNS symptoms, but with the advent of newer ARTs, those symptoms are less. Even other medications might be responsible. The presence of iris and something which is unrelated to HIV can always happen, and that has to be kept open as a differential. So neurological illness occurs in 40 to 60% of HIV infected people, and the focal brain lesion include almost 17% of it, which includes toxoplasma, PML, and primary CNS lymphoma, which is not so common. Commonly, what we see is tuberculomas, which will be a first differential. Non-infectious include encephalopathy, seizures, stroke, peripheral neuropathy, and other manifestations. So it's the same list. So few things I like to highlight before moving on to case. One is polymicrobial infections are always possible. I have had patients with TB, toxo, TB, crypto. So all multiple combinations, TB, CMV. So all these we have seen. Multiple organ system can be simultaneously involved. Clinical manifestation can be masked due to immune suppression. And meaningful survival is dependent on rapid diagnosis and timely initiation. This I'll highlight again because this is really crucial. So, starting with this case, 35-year male recently diagnosed HIV at CD4 of 123, viral load was pretty high, presented with altered sensorium, MR brain was reported normal. CSF opening pressure was 40 with 23 cells, glucose was 46, protein was 78, CRAG was positive, significantly positive, and India Inc. was also positive. This patient was started on amphotericin and flucytosine. But one point here, important point here is this patient, the moment he got diagnosed with HIV, he was started on ART. Though he had headache in the beginning, CSF was not done. The only MR, CT brain was done, which was normal, and he was put on ART. So possibly it was Cryptococcus which was cooking in, and that was kind of poor prognostic factor for this patient. So when we think about the diagnostic workup for cryptococcal meningitis, what is available with us is India Inc. cultures, CRAG. In CRAG, what is available is lateral flow assay, which are really which are commercially available and which are really good sensitivity wise. So if we compare this head-on comparison, LFA, the sensitivity was almost 99%. If we do CRAG by latex, it was 97%. Culture is 94% and India Inc. is just 86%. So whenever we have suspicion of cryptococcal meningitis, we should ask for cryptococcal antigen LFA test. And even if we have biofire, sometimes the film array panel, multiplex PCR, that can miss cryptococcus. So if the suspicion is really higher, we should repeat cryptococcal antigen. So this was a study wherein they have noticed that LFA identified 6 additional persons with cryptococcal meningitis that were not detected by any of this. So that's a real good number. And when we know cryptococcal meningitis, the mortality, the immune reconstitution, all those things are really important. So picking it up early is crucial, and that way LFA will definitely help us. What are the poor prognostic signs or factors for cryptococcal meningitis? Basically, use of steroids, cryptococcal growth from other sites, so extra CNS involvement, altered mental status, elevated CSF ratios more than 20, low glucose less than 40, low cell count, which is poor inflammatory response, CSF CRAG more than 1:1024, again is a poor prognostic factor, and this patient had this. Positive India Inc. after 4 weeks of treatment and low glucose at the 4 week of treatment. Those are again predictive of relapse or recurrence or poor prognosis. The intracranial pressure elevation can cause clinical deterioration despite a microbiological response and is more likely if CSF opening pressure is more than 25. When should we do CSF culture? So 2 weeks of CSF culture ideally is recommended irrespective of clinical response, basically to predict the future relapse or less favorable future outcome. Serum CRAG is not recommended for follow-up. Serum or CSF CRAG is not recommended. It's just prognostic factor, and it's not recommended for follow-up monitoring. So what is interesting in cryptococcal meningitis is this NEGM study wherein they have used high dose of amphotericin, which similarly like what we do in leishmania and other few infections we have tried. So this high dose of amphotericin, what they did is liposomal amphotericin 10 mg per kg single dose, and compared it with 1 week and 2 week of therapy. So in phase 2, single dose, 1 week and 2 week of therapy was compared. Along with amphotericin, what they have done is they have given oral flucytosine 100 mg per kg per day and oral fluconazole, high dose fluconazole, what we gave. So 1200 mg of fluconazole. And the mortality was 24 versus 30 versus 45. So significant low mortality in those who have received single dose amphotericin. And this was probably attributed to the low side effect adverse effect profile. So if we compare adverse effect profile in the study arm, which is single dose liposomal amphotericin versus the 1 week or 2 week what we give, adverse effect was just 50% in this arm versus 62% in the control arm. And death from any cause at 10 week was nearly equal or more or less with the liposomal arm. The other thing advantage was it's easier to administer and fewer drug related adverse effect, which we know basically with conventional or liposomal amphotericin. Longer the duration of treatment, higher is the chances of renal failure or metabolic imbalance or tubular damage, renal tubular damage, and RTA, what we see in all these patients. So this was non-inferiority trial and the adverse effect profile was really low. So with this, the WHO guideline has been updated and this has been included as a one recommendation for cryptococcal meningitis if patient is financially affording and if this is available. What should be recommended is liposomal amphotericin 10 mg per kg single dose plus 14 days of flucytosine and high dose fluconazole. If this is not available, then the alternative regime is 7 days conventional amphotericin plus flucytosine followed by fluconazole. If flucytosine is not available and we are giving amphotericin with fluconazole, then it is 2 weeks of amphotericin, conventional amphotericin plus fluconazole. If amphotericin is not available, then it is 2 weeks of high dose fluconazole plus flucytosine. And with all these, we need to monitor electrolytes, we need to monitor the for pancytopenia with flucytosine, with fluconazole, hepatitis, we need to monitor, and even with amphotericin, liver toxicity and renal profile, we need to monitor. Particularly electrolytes, hypokalemia needs to be monitored very cautiously. Is there any role of steroids? This was an old trial, but it's really important because steroid didn't found to help in this patient. In fact, they were ineffective in managing the intracranial pressure and they are not recommended. Acetazolamide also should not be used as therapy for increased ICP management since it may cause hypochloremic acidosis and does not result in decrease in ICP. There was a randomized trial where they have compared 6-week course of tapering dose of dexamethasone with placebo among 451 Asian and African patients with cryptococcal meningitis. And what they found that it didn't improve survival through 10 weeks. And in fact, it was noted to decrease the killing of cryptococcus and was associated with more adverse effect. So use of steroids should be avoided when it is cryptococcal meningitis. So when to start ART? Now I guess the trials or the data is pretty clear. Earlier ART, the risk of immune reconstitution and treatment failure are highest. So deferring ART for 5 weeks is been recommended in patients who have cryptococcal meningitis. Screening about asymptomatic cryptococcal antigenemia. So rest of the guidelines, they say 100, and what we follow in NACO is criteria of CD4 of 100, but then African guidelines says at CD4 less than 200, we should screen for cryptococcal antigen. If the serum cryptococcal antigen is positive and patient is symptomatic, we should do a CSF. If patient is asymptomatic, just fluconazole prophylaxis, and those who have CSF negative, we give 2 weeks of fluconazole. Same is true for those who are asymptomatic and serum cryptococcal antigen positive. The another problematic thing in managing cryptococcal meningitis is relapse versus iris, and it practically becomes difficult in differentiating relapse, iris versus persistent infection unless and until our initial workup is really good and we are doing the cultures and following our protocols completely. So, and why is it important? Like in initial cryptococcal meningitis, use of steroids is not recommended. So how do you manage iris? How do you manage microbiological relapse? Or when do you suspect the presence of antifungal resistance? So all these things need to be monitored properly. So in that, the cultures definitely helps us. Cryptococcal antigen high levels will help you in realizing that yes, it's a poor prognostic factor and you need to monitor, you need to do the fungal cultures properly and monitor them. So what is important is review the patient's history in whether there is inadequate drug dose regime, dose, duration, and that happens actually with all these multiple permutation combinations. We do mess up sometimes and we do miss out on the duration and the continuation and maintenance phase. Poor adherence to fluconazole. I had a patient of cryptococcal meningitis who used to recover every episode and then they used to go back and defaulter, and she used to come back again with cryptococcal meningitis admission. Culture used to be negative, But then she had 3 or 4 episodes, and after that, unfortunately, she was lost to follow-up. Underlying fluconazole drug resistance is there or not, that has to be clarified, and for that, cultures are really crucial. So what is advisable is perform a lumbar puncture, measure opening pressure, exclude concomitant illness. That is again important, whether there is coexisting TB or some other opportunistic infection. And those who have prolonged fungal cultures like 2 weeks of incubation, then the chances of relapse or persistent infection will be, we can label it as persistent infection. Moving on to a next case, 25-year female who had no comorbidities, presented with fever, change in appetite, weight loss, no history of TB contact, labs were pretty normal, chest X-ray was normal. Sorry, this is HIV positive patient, not negative. CT chest showed subcarinal nodes. CT guided biopsy showed caseating granuloma. AFB was negative. This was the lymph node. Gene expert AB smear were negative. Weight-based ATT was given. She responded. No fever. There was weight gain. So, but then, sorry. So she responded, there was a weight gain, and then she came up with this lymph node actually. So there was worsening of lymph node. So what should be done? What would you think? What is happening? So we will check the ATT compliance. We'll rule out absorption issues, because we know rifampicin, INH, all these have erratic absorptions, and we have the therapeutic drug monitoring available. We will go for that. We'll think of drug resistant TB, or there is something else, other etiological diagnosis. So for our rescue, the AB culture was sent in the beginning, and that grew MTB complex and culture. So it proved that yes, it is MTB. So yes, we have good diagnostic test available with us, and with availability of expert ultra, which has been studied in HIV population. So there are 2 prospective studies carried out in African cohort, and they have found out that sensitivity of ultra was significantly higher as compared to the expert expert what we use, MTB expert and midget, in diagnosis of TBM in HIV population. So it's really a good savior for us, particularly in HIV population. The another thing is pyrosequencing, which is not commercially available, but particularly for the patients with TBM, it's really a good tool, because if we compare this versus expert and midget, the sensitivity is 98% in pyrosequencing versus 43% in expert for CSF and 45% for TB midget. And the other thing which is advisable is those who, the another practical problem we face in TB population is TB iris. And sometimes they just present with TBM and subsequently they get spinal issues and other things. So what is recommended is those who are presenting with TBM, especially with concomitant HIV, they are at higher risk of developing cord involvement. So a gadolinium enhanced MR imaging of the spine in these cases, that will help in detecting the occult nodule or granuloma if they are there, and predicting whether it was a TB iris or it was initially there. So all this screening helps in follow up this patient. So this girl, to add to the history, this girl had stayed in Mumbai for 2 years, and we know the risk of or the incidence of MDR TB is pretty high in Mumbai. So will I be thinking of MDR TB now? I have MTB culture positive. So what should be done? Will I wait for 3 weeks for culture to come positive and move on? Or what should be done? So LPA is available and we can advise cultures, LPA on culture. So LPA was done first and second line and both were sensitive. So this was a case of drug sensitive TB. And then the lymph node positivity or lymph node enlargement was basically because of immune reconstitution. So as I said, expert TB, this is, sorry. So use of expert, MDR expert actually, XDR expert panel is available. So if LPA is not available, expert, and you have gene expert, the expert XDR panel is available. And sensitivity of this panel is really good. One of this study site was from India. So yes, this has been studied in Indian population with the mutations present in Indian population also. So 55% sensitive of sorry, the expert was 94% sensitive for INH, 95% was for fluoroquinolone, 54% for ethionamide, 73% for amikacin, and 86% for kanamycin, and 61% for caprio resistance detection. And specificity is really good, almost 98 to 100%. And the performance is equivalent to line pro buses what we use. And non-determinate rate of expert MTB was 2.96, which is 3%, which is acceptable. So if we have this test available, we can utilize this test on the cultures and get the prediction rather than waiting for a longer duration. So the practical issue in this patient was not the drug sensitive TB, it was the immune reconstitution. And do we have a definition? Yes, we do have a definition to label immune reconstitution. Basically, what is important is there should be a clinical response followed by worsening. Iris might be unmasking iris, and um, there are two types of iris. So what is important is rapid restoration of pathogen-specific immune response causing either the deterioration of treated infection or new presentation of previous subclinical infection, which is unmasking iris. So it typically occurs during initial months of therapy, but sometimes we have had patients wherein delayed immune reconstitution was there. Generally, those who have very low CD4 count, they do present in early phase with the immune reconstitution symptom, and that's why we advise them to keep checking for all these signs of worsening clinical presentation or any new presentation. It might be which happens in unmasking iris. And confirmation relies heavily upon the case definition incorporating clinical and lab data. So unless and until we rule out drug-resistant TB or other coexisting infection, labeling patient as unmasking iris and bombarding patient with steroid is practically not possible. So in HIV populations, if we compare the risk of iris is 2% in HIV seronegative versus 7% in those who are not on ART and 36% in those who are on ATT and ART. So the risk of iris is higher in HIV population as compared to non-HIV population. Even in young immunocompetent people, we do see seroconversion in this immune reconstitution pretty commonly. Moving on to next case, 43-year male with HIV had pulmonary TB. EKT was started and almost 4 weeks of 4 weeks later ART was started. After 2 months, the right cervical node swelling, which was not there earlier, that appeared. So what should be done? The CD4 was 56, weight loss was there by 4 kg. Whether we operate or continue on the same AKT, operate and start second line AKT, operate only or give steroids or do nothing and observe. So as I said, what is important is rule out whether it is drug resistant TB or not, or whether it is drug sensitive TB. Once we are sure whether it is drug sensitive or drug resistant, then the decision of changing first line or second line can be done. And then the decision of adding steroids or not also can be taken. So this turned out to be MDR-TB. Patient was started on second line treatment after 1 month of complaint of swelling on left side now. So CD4 was improved and it was virologically undetectable. So that means patient was virologically better and there was an immune reconstitution which was already there, and despite of that patient was improving. When the node was worsening and patient was already on second line MTB, so that anti-TB treatment. So this was a case of immune reconstitution syndrome not responding to anti-TB, and there comes the role of steroid, whether to give steroid to the patient or not, or whether to operate. So all these lymph nodes, if you drain them in time, it does help. When to give steroid, I'll come to that in the subsequent slides. So smear and PCR positivity does not include viable mycobacteria, and that is one thing we have to always keep in mind. Only a positive culture consistent with clinical picture validates presence of drug resistance. So what will be the clinical approach? Suspected paradoxical response. If we are suspecting anything, we should check if there is surge in absolute lymphocyte count, which will happen if there is paradoxical response. Know the incidence and prevalence of drug-resistant TB, whether I should suspect a drug-resistant TB in the patient or not. And if I'm suspecting, I should get the workup done like the expert MTB, LPA, expert XDR, all these things we can do. If we have pyrosequencing and the suspicion is really higher and any of this is negative, we can go for that also. So all these rapid diagnostic tests definitely helps in ruling out the resistance, and once it is ruled out comes the role of steroids. So use of steroid in immune reconstitution has reduced the death by RR of 0.69 is significant. And then there is reduced need for hospitalization, therapeutic procedure, and hastened improvement in symptom performance and quality of life. So steroid is mainly recommended, and it's proven to be helpful in this population. If the lymph node persists, or particularly uh, if it is not responding to steroid, aspiration of lymph node definitely helps. If despite of all this, yes, there is data and there is practical experience that lymph node persists, and it takes a while, a few weeks or months for lymph nodes to disappear. And the same thing happens with intracranial tuberculomas also. And there is enough evidence and publications that it takes, quite significant amount of time to settle down. So we cannot have a radiological clearance before stopping steroid therapy. That is completely a clinical decision, and there is no clear-cut guideline for how long to give steroids and when to stop steroid. So the important points are basically paradoxical response is rare but more common than drug resistance. So that should be kept in mind. But drug resistance should be ruled out with the help of tissue or specimen cultures, which are really crucial. Rapid diagnostic tests should be that will expedite the diagnosis. Steroid may be required in case of tuberculoma, widening mediastinal lymph node, or intestinal TB causing subacute intestinal obstruction. And if there is persistent, surgical excision will definitely help. Moving on to next case, a young male, 42-year, was diagnosed pretty long back, but he never got started on ART because he was hesitant for being on ART. Presented with fever, lethargy, occasional headache. He had CD4 of 500 few months back, and then it was 350 CD4. That's why he came in here. And the workup showed bicytopenia, MR brain was normal, fundus examination was normal. Because he had headache, all these things were done actually. And on neurological examination, he was completely fine. There is no focal deficit, no cranial nerve involvement, nothing. But then wife always used to say, sometimes he has this lost spell and he just forgets the thing. But whenever we used to examine the patient used to be normal. So CSF was done, CSF was normal, crack, gene expert, all this workup was done on CSF, which was normal. Serum cryptococcal antigen was also done, that was normal. And since there was bicytopenia, bone marrow was done, and hematopinion was taken, that turned out to be normal. So we thought might be bicytopenia is because of HIV per se, and we got the patient started on 3-drug therapy. Marrow was not improving, and then the patient got admitted with seizure episode. So we did CSF, we did MR brain, and to our surprise, this was the MR brain of this patient. And so here you can see significant ependymal involvement, these infarcts, periventricular infarcts, and hydrocephalus. So within a span of 1.5 months, this patient presented with this kind of presentation, and the CSF multiplex PCR came positive for CMV. Then we did further workup like fundus, which showed CMV retinitis. So this patient got started on ganciclovir. He improved partially, but then subsequently had another turn of event, nosocomial infection, and I lost the patient. So initial clues to this patient were just bicytopenia, but then the complete workup was negative, and at CD4 of 350 and 500, we hardly suspect CMV. So even in this patient, we never suspected, and even the bone marrow was negative. So he never got started on CMV therapy. Fundus was completely clear in the beginning. And just in a month time of starting ART, this patient had this unfortunate turn of event. So when we think of CMV, though we don't see CMV retinitis and CMV encephalitis that common in HIV population nowadays, but yes, this was an eye-opener for me, and that has to be kept in mind. So what are the presentations we see? Basically, retinitis. GI presentations include esophagitis. This we see sometimes actually, gastroduodenitis and colitis. Pneumonitis is a rare presentation. Neurological presentations, adrenal involvement, hepatobiliary system involvement. So HIV cholangiopathy, one of the differentials is CMV definitely. In neurological, the incidence is 2%, and that too when CD4 is less than 50. Those who have high CD4 there were reports of CMV retinitis and neurological involvement also, but they have very less incidence if the CD4 is above 100 or 200. The incidence has definitely gone down with ART and the antiretroviral therapy what we use. The presentations include ventricular encephalitis, ascending polyradiculopathy, and dementia. So this patient had dementia and subsequently had a significant ventricular encephalitis. What are the confounding factors? So at this CD4, if patient is presenting with CMV and this profound CMV presentation, the confounding factors are basically presence of the particular HLA type, viral stain, and the immune response of the patient. So all these factors can contribute to unusual presentation at higher CD4. CMV retinitis, it's a common manifestation of CMV disease, almost 85%. So in fact, it was a dictum in the beginning when we started managing HIV patient that those who have low CD4, we should do a fundus examination to rule out CD4 CMV retinitis. But those who have CD4 above 100, the incidence of CMV retinitis is not higher, and that's why it's not mandatory to do fundus examination. But if you are following the protocol, it's really good, particularly after burning hands like this patient. But having said that, there is no guideline to regularly do a fundus examination for those who have CD4 above 100. Hematogenous dissemination of CMV after reactivation of latent CMV infection is what is the pathogenesis behind this. What we see is hemorrhagic retinal necrosis, irregular dry appearing granular borders with little vitreous inflammation. The incidence of immune reconstitution uveitis is 0.02 per person year after immune recovery. So there was one study which demonstrated substantial increase in immune reconstitution uveitis in association with immediate as opposed to deferred initiation of ART. So 71 versus 31%, which is a significant difference. But the benefit is not significant, and that's why in current era of antiretroviral therapy, it is not recommended to delay ART just for avoiding this immune reconstitution syndrome. The GI disease, what we see is esophageal ulcers, strictures, colitis, and colonoscopy, biopsy, definitely helpful. What we see is inclusion bodies. So histopath will show us these ulci, intranuclear, smaller intraplasmic inclusion bodies on tissue specimen. CMV DNA PCR measurement is helpful, but it's not the diagnostic of end organ involvement. So negative DNA PCR, that doesn't rule out end organ involvement. Treatment wise, what is recommended is intraocular ganciclovir implant plus valganciclovir for retinitis. For CNS involvement, IV ganciclovir, and then we can switch to either continue IV or we can switch to valganciclovir, provided the GI involvement is not there, because absorption issues will be there. In case of resistance, we can use foscarnet and cidofovir. So duration for induction is what till your plasma viral load is undetectable for 2 occasions, or till the patient symptom improves, we have to continue the induction therapy and subsequently move on to the maintenance therapy. When do we suspect antiviral resistance? Is basically if there is no clinical response or virological reduction during 2 weeks of full dose or 6 or more weeks of cumulative antiviral drug exposure. So in that case, we should suspect virological resistance and work it up. There are few factors, or which are few things which we have to keep in mind, particularly managing these patients with opportunistic infection. Like sometimes they are in ICU, we cannot give them medications. So which tablets can be crushed and which cannot be crushed, or which can be managed in ICU patients. All these things, knowledge about this definitely helps in managing the patients with opportunistic infection. So basic problem comes with PIs. Actually, otherwise, the present regime, what we use, dolutegravir, FTC and 3TC is easily manageable, and we can continue even those with trials too. Before moving on to last few slides, I would like to highlight this, what is updated last month actually. So there are 2 updates in OI. Basically, one is about immunization, topic close to my heart, and the second is about hepatitis B. So the vaccine recommendation include double dose recombinant hepatitis B vaccine, which should be included. And the other emphasis is on avoidance of dual therapy, what is being practiced now for those So hepatitis B should be excluded because we know lamivudine is pure agent for hepatitis B and the resistance rate will be higher. So, and in immunization, the update is basically Western countries have moved to PCV 20 and PCV 15. So pneumococcal vaccine is moved to 20 valent. If it is 20 which is used, it's just single vaccine. And if we are giving 15, then we have to give 15 followed by 13 valent. And zoster vaccine, which will be available mostly next year in India, is recommended for those with HIV and those who are 18 years and older rather than 50 years and older. So that is another update which I thought I should highlight. So take home points I'll say is initiate ART as soon as possible with most opportunistic infection within 2 weeks. The delay is required, particularly when we have CNS involvement with high risk of iris like TB, cryptococcal meningitis. Even for pneumocystis, what is recommended is 2 weeks. In 2 weeks, we can start antiretroviral therapy. Drug-drug interactions should be kept in mind, and particularly while managing the opportunistic infection, also all those things should be kept in mind. High index of suspicion and thorough workup can avoid risk of unmasking iris. So if we pick it up early and treat it, we can definitely avoid the risk of unmasking iris or missing those OIs in the beginning. Newer diagnostic modalities like this gene expert and the PCRs, what we have available, have really good sensitivity and specificity, and they should be appropriately used. And for critically ill patients requiring intubation, as I said the last slide, those who have swallowing difficulties and ability to crush or give alternative ART formulation, we should be well versed with that. Thank you.
Oh, thank you very much, ma'am. We had a very interesting real life case scenarios, 4 to 5 case scenarios, and when you explain all of the things. And the crux of the story is that we need to start early and we need to have a high level of high index of suspicion, and we need to also consider that there might be a polymicrobial infection and involving multiple organ system, and rapid diagnosis and starting early is the most important thing which I could understand from this presentation. So there are 1 or 2 questions, ma'am, and I could see there are more than 100 participants in this session, despite this is a weekday and middle of the week. So there's a question. What is the name of the doctor? I can just Vineet VK. He's asking your opinion on MAC prophylaxis in stage 4 HIV.
So MAC prophylaxis, the incidence of MAC in India is not significantly higher, but then NACO program definitely recommends MAC prophylaxis clarithromycin in those who have CD4 less than 50 stage. So that is there. But in practical, I don't practice MAC prophylaxis because incidence of MAC, what we see in our day-to-day practice, is pretty low. Recently, in fact, now I have a patient who had HIV diagnosed few months back. He had pulmonary involvement and he had GI involvement. The biopsy showed gene expert negative, AFB positive. So that indicates presence of MAC. So he was started on MAC therapy. He worsened subsequently, and now he got admitted with us with CNS lesions. So it's more like a MAC iris. And we are working up that patient. His culture came positive, and again it was negative for gene expert. But these are very few cases. So incidence of MAC is not so high in our population. Sir, but yes, NACO does recommend MAC prophylaxis.
Ma'am, senior doctor from Hubli, Dr. Bharat Raj, he would like to ask directly to you. I'm just allowing him to talk.
Sure, sure.
Over to Dr. Bharat Raj, sir. You can ask your question. I think you need to unmute and ask your question.
Good evening, sir.
I think, sir, might be busy. Let us go to the next question by Dr. Vineet again. Do you routinely advise HLA B5701 sensitivity before starting abacavir? I
do advise it. And because the hypersensitivity is really significant. So I have had 2 positive recently, HLA-B 5701, and then I have avoided abacavir in those patients. But yes, this positivity rate is pretty low, but still, yes, that's a protocol and I do follow.
Ma'am, in your presentation for CMV, you do mention about cidofovir after ganciclovir. So what would be, and you mentioned the dosage also. So it would be a 14 days, or one can go beyond 14 days as well.
The duration of therapy again depends on the clinical response and virological clearance also. So it's not only 14 days.
Okay. Okay. And the dose would be 5 milligram per kg, what you mentioned.
Cidofovir, I have never had chance to use cidofovir.
Okay.
So far never had come across with ganciclovir
Okay,
resistance.
ma'am, there are various good, I could see there are in a question and answer session, there's a very, what you call as a rewarding comments, excellent session. And Dr. Bishal Gupta, I want to ask how to counter and diagnose PML in HIV.
PML is again radiological diagnosis majority of the time. What we can do is JC virus PCR is available and we can check those PCR. The sensitivity is good. And we have had patients wherein JC PCR was also positive. But what is important is your radiological presentation and clinical suspicion. Again, here PML, like in CMV, what we burn our fingers, PML also, we do see PML at CD4 of 300, 400, 500 also, and a bad full-blown PML. So we should never think PML is there only at low CD4.
Ma'am, there's another question, when to give IPT in HIV patient?
IPT in HIV, yes, it's been practiced, it's there in the guideline, but again with the MDR scenario, whether to give it or not is debatable. NACO do recommend IPT prophylaxis for those who have low CD4 or those who are in contact with TB population, open TB patients. I am not practicing IPT prophylaxis.
So ma'am, related to PML, there is another one interesting question comes, role of pembrolizumab in PML.
Pembrolizumab in PML, I haven't used so far.
Okay.
Or not read about.
But another interesting question, what we are talking, you have elaborated about tuberculosis and one of your case. So there's a question on your opinion of isoniazid prevention therapy in a private practice.
Sorry, I missed it.
Yeah, so he's asking Dr. Sunil Patwardhan. Dr. Sunil Patwardhan would like to know your opinion on isoniazid prevention therapy in private practice.
Ionist prophylaxis, that's what I said. I don't practice. Basically, there are two school of thought. So the guideline do recommend African and NACO do recommend IPT prophylaxis for those who have low CD4 or those who are in contact with open TB patients. But when you know you are sitting in an area with high MDR, TB, INH monoresistance is more than 30%. So it's very difficult to practice INH prophylaxis. So I don't practice it.
Okay, another point, Dr. Aniket Gangode wants to know preferred ARV for the TB patients on rifampicin. Based on
we can give dolutegravir double dose, and that's what I'm using nowadays. Previously, we were giving efavirenz because PI has a lot of drug interactions. So, but with dolu double dosing, the job is easy, and the side effect profile is also low. So, hepatotoxicity and all, we don't have to worry.
So, same Dr. Aniket Gangode would like to know one more thing. What is the best ARV for HIV with high CSF viral load?
High CSF viral load, again the dolu CNS index is 4, so it's good. And even for lamivudine, the CSF index is good. So just this TDF FTC will do for high CSF penetration. Or we can use pseudovidine plus lamivudine and dolutegravir.
So one practical experience I would like to know by Dr. VTH Swami. He is asking you, do you see darkening of the skin?
We do see darkening of skin with dolu sometimes. Yes. So a weight gain, impaired glucose tolerance, and skin darkening. These are the three major issues we are facing as of now.
How many doses of RZV vaccines? I think I am not very clear. Your opinion?
Is I guess it's zoster vaccine.
Zoster vaccine now. The zoster vaccine. Yeah.
Zoster vaccine is 1 dose, what I recollect, or what? Sorry, I'm not recollecting. Yeah.
Yeah, so I think we have covered almost all questions. So
Opinion on beptegravir or dolu bed gain. Majority of my patients are on dolu, not on beptegravir, so I'll not comment on that. So I don't have too much of experience on beptegravir, so I'll not say there is no weight gain with that.
there's another question by Dr. Rutu Dekne. What he asked, what is your opinion on IPT for the people who are about to receive biologicals or monoclonals like rituximab and for other conditions?
So those patients, when we are working it up and there is latent TBS, we should be giving INH prophylaxis.
Okay, I think, ma'am, we had a very interesting power-packed session for a complete 1 hour. It is almost more than 50 minutes we are discussing on the opportunistic infections. And as you highlighted, high index of suspicion and do not delaying of the treatment and start early and hit hard. And do keep mind in a drug-drug interactions. So these are the few important crux of this presentation, and very interesting 4 real-life case scenarios and very diverse, which we have discussed today. Thank you, ma'am, for your excellent deliberation. Thank you all the participants. On the weekday, we have a gathering of more than 100 delegates attending this session and asking many of questions and showing a lot of enthusiasm today evening. With this note, let us stop at this point of time, and we will connect again with more expert with a few different case scenarios and the topics. Thank you very much and have a nice time ahead. So we are closing this program. Thank you very much.
Bye.